Okay, I think we will get started. So welcome everyone to SADS Foundation's 16th webinar in our Living with SADS series. Tonight, Mind Over Body, Trusting Your Safety Nets. I'm Marcia Baker, Program Director for the SADS Foundation. We are pleased to see so many people register for this popular mental health topic and with the renowned Dr. Sam Sears to join us. So before beginning the webinar, a couple of reminders. Please keep your audio muted during the presentation to improve sound quality for all. Following the presentation, Dr. Sears will address your questions. You may type your question into the chat field anytime during the presentation, and we will address them at the end. Our webinar is being recorded for additional viewings. It's now my pleasure to introduce our speaker. Dr. Sam Sears is a professor and cardiac psychologist at East Carolina University in both the departments of psychology and the Department of Cardiovascular Sciences in Greenville, North Carolina. Dr. Sears received his education at the University of Florida in psychology, where he also completed his advanced degrees, Master of Science and PhD in clinical and health psychology. He is a nationally renowned expert in the psychological care and quality of life outcomes of patients with ICDs. At East Carolina Heart Institute, he provides clinical services to cardiac and ICD patients in its cardiac clinic. He has published over 150 articles in the medical literature on the psychological aspects of cardiology, including depression and post-traumatic stress in patients with ICDs. We are honored that Dr. Sears is volunteering his expertise and time with us tonight. So thank you, Dr. Sears, for sharing your knowledge with the SADS Foundation's patients and families. So welcome.
Thanks very much, Marcia. Well, it's great to be here, and thank you so much for joining us tonight on a little bit later evening on the East Coast, and welcome folks from around the country and Canada as well. So thank you for being here. As a psychologist embedded in cardiology over the last 26 years, mind over body is a rallying cry. That is, our patients often say, how do I overcome the effects of the body? And I would posit tonight that part of the challenge is mind and body, that total health is what we're really going for. And you see, the problem is, like, we all want to be safe. And the fundamental building block of psychological wellness that we're going to talk about tonight is trusting safety nets. Now, it's understandable if you want to do everything possible to keep you or your loved ones safe. I mean, this poor guy's having quite a day, right? But as you can see, sometimes creating this kind of safety can be impractical or can be overbearing. That instead, this concept tonight about safety nets is advanced because safety nets allow us to perform. They allow us to achieve greater heights. In fact, Cirque du Soleil is a performing troupe in Vegas and around the country. But one of the secrets to their success and their daredevil tactics is that they have a safety net below the stage. That the sight lines for those watching the circus don't see the sight line. The sight lines don't show the safety net. But the safety net's as important in the performance as the skill of the performers. Safety nets allow us to get work done. Safety nets in the occupational setting allow people to work and achieve and know that somebody's got them if things went adverse. I mean, sometimes we want people to be aware of safety nets. This classic picture of these guys working on New York City. I mean, there's just something scary about, hey, where's your safety net, right? It's the first thing you look for. But that's the fundamental challenge psychologically that we want to talk about tonight. That while it can feel a little bit trite to describe safety nets as so important, it's really an essential part of the psychological health. It's the basic building block. So tonight's not so much about how to boil the oceans or become psychologically a superhero, but it's to establish the basis that the fundamental challenge our patients in cardiology face, and you and your families face, is to somehow feel safe while being aware of the threat. And that idea is what I'll call cardiac safety or cardiac security. And I'll make the point tonight that as you go through the processes of care, the purpose of that care is to hopefully make you feel safe. I took this picture at my Lowe's, back by the restrooms. They have the occupational safety regulations and things like that. And I took this picture right here in Greenville. Safety is when nothing happens. And I thought to myself, I guess I know what they mean, but safety is really an active process. I think what they meant to say was that prevention prevents things from happening. But safety means that some active process is put in place to reassure and to help people perform. And that safety nets are part of that. So when we look at this tonight and we talk about safety nets, why the focus? Why is this so important? Because if you go all the way back to some basic psychology from Abraham Maslow's work, where he looked at the hierarchy of human needs. And what he did was he wanted to understand how do people overcome the terrible things that happen to them. He was actually interested in survivors of terrible traumas, Holocaust survivors, and other folks who experienced some of the most terrorizing effects of life. And what he did was he showed, of course, that psychological wellness was built on the building blocks of what I'll call survival, right? So food, shelter, water, my children would put Wi-Fi in there. I might add coffee, but survival, the basics of survival. But just above that was the perception of security, that one could not really achieve self-esteem or social acceptance or become all you wanted to become, which is the idea of self-actualization, if they didn't feel safe. And safety in the context of heart disease is an achievement. That it's actually really hard to simply feel safe by convincing yourself of it when you know that you're dealing with various kinds of cardiac concerns. Yet that's the very task that we face. A different way to look at this would be that we want to prevent premature death, that nobody can prevent death 100% all the time. But what we want to do is produce a plan that prevents premature death and then produces a feeling of security. And then and only then do we worry about these other kinds of things like self-esteem or happiness even, or contentment. I tend to use the word contentment as opposed to happiness. Being content, being aware that there are many good things in life. Perhaps gratitude's another way to say that. Those kinds of valuable psychological states, they all build on the idea of, can we feel safe? It makes sense in a way, right? If you feel like you're in harm's way, it's very hard to go and want to enjoy some aspect of life because harm's way has a way of intruding on your attention. So it brings us to our idea about quality of life, right? Quality of life is the idea that even in the context of health or disease, that there are biologic aspects of health, the aspects of our body that are simply physiological. There are psychological aspects of our life which have to do with our mood and our emotions and even our memory and our attention, our thinking processes. And then there are social aspects, which is how all of us perform the roles in our life. How do we become and be an employee or a dad or a brother or a sister, a spouse, a partner? That these aspects of our life, that these are the elements. But there's the reason a psychologist is on the SADS telecast tonight is because the psychological side of living with any disease, including heart disease, is often missed by our healthcare system. Our healthcare system tends to focus on crises. It tends to focus on emergencies. But what about the longevity living? What about the idea of going on, keeping calm and carrying on? How does that even work? And that psychologic side of things often gets left behind. And that's clearly what I'm trying to represent tonight to address that. And one of the reasons is because heart patients across the board, about 1 out of 4 deal with psychological distress, meaning that 25% of the patients that walk into any heart clinic are dealing with anxiety and depression at rates that are problematic or getting in the way of their being able to find peace, getting in the way of their being able to feel energized by life, enjoying life. However you want to define depression and anxiety, there are a couple of ways to define it, but basically it is, of course, the fear of losing, of the threats of losing something, that's anxiety, or the actual loss of something that you loved or cared about. That's that depressive or sort of hollowing out feeling. Regardless, 25% of our heart patients experience that. I would suggest that the contrary to that, the opposite of that, is that as a heart patient, we strive to help our patients feel normal. We strive to help our patients feel safe, and we strive to help our patients be active in their life in some form. And so this idea of normalcy, safety, and activity are things that we keep in the forefront of our minds as we take care of folks. And I think they're part and parcel to your experience of living with cardiac disease. My work's been focused on ICD patients, and many of the things that I'll talk about in the next 2 slides have to do with ICDs, but they're much more generalizable than that. I'm aware that not everybody on the call tonight has an ICD, but I wanted to highlight that there is a science to what we're talking about tonight, that this has been a focus of our work for 26 years. So when you look at the first 3 rows here, whether it be depression or post-traumatic stress or general anxiety, you'll see again that if you sort of find the median of all those, it's around 25%. But again, 25% of our patients with an ICD or any cardiac disease cross-cut those first 3 rows. But our ICD patients also deal with shock anxiety, so worrying about the ICD. Avoidance activity is worrying about doing too much or not doing enough or somehow finding a way to get the right amount of activity. And then across the board, most of our patients continue to learn or need to learn about their ICD and about their condition. And again, I think most of you know that. You're on the call tonight. Hats off to you. Learning and engaging with material about your heart is a sign of psychological health, because it's easy to avoid things. It's easy to sort of disengage and not try to hear about it, right? I don't want to hear about it. I'm tired of talking about my heart, right? And you'll see that from time to time. But that avoidance, that disengagement can actually lead to more problems over time. That I like to say to my patients, there's nothing you can't learn about your condition or your device. There's nothing you can't learn about your medications. That instead, you can have an excellent working knowledge about all of those things. And sometimes you might actually need that working knowledge. There may be a situation where you know more about your device or your condition or your diagnosis or your medications than whoever might be attending to you at that time. So becoming, a semi-expert still makes some sense. Well, we've also looked at who is much likely to have distress, who needs to pay attention to safety nets more, if you will. And you'll see there in the circle, the group of patients that have risk factors we'll call for psychological distress. Again, patients less than 50 years of age with a cardiac illness of any sort are more likely to report distress than our older patients. Women are more likely to acknowledge distress across the board and in virtually every population. And as you go down, patients with previous problems psychologically, stressors, low social support, that is, they don't have anybody to talk to, poor understanding of their condition and device, and more severity. Those are folks who are more likely to need additional help. Over on the resilience side, factors that help people buffer the effects of stress, optimism, positive health expectations. And I'll highlight down a little further faith in ICD and doctor. And that's because those are safety nets in particular, consistent with what we've talked about tonight in terms of A safety net is that technology, that person, that medication, that family member who can provide that. Because the challenge of living with heart disease in the long run is that it's a daily task to feel safe. And while that's a pain in the butt, and I wish I could give you the magic button that says, you'll always feel safe if you do this, that's not quite how psychological health works. That it's a daily task in which fears will emerge in your thinking from time to time. And at times you will need to be deliberate in finding gratitude or positive aspects, even if that seems silly or trite. Those things remind us of the value of living, and we'll talk about that as we go. But creating security is a daily task, so you never really get to say, been there, done that. What I want to talk about tonight then is 3 types of safety nets, and then I'll complete my comments and open up for questions. I want to talk about 3 types of safety nets that I think all heart patients need to identify in some way, shape, or form. I'll talk about objective security, I'll talk about subjective security, and then finally active security. Okay, so first, subjective security. So I mentioned earlier that one of the primary tasks of going to a clinic, of going and getting medical care, is to objectively minimize risks. That in this slide, you see a bunch of things that can help reduce risks, that essentially can minimize and take away some of the risks associated with your condition. The most common one, of course, is medications. We use medications to control heart rate, to change the rhythms of the heart as necessary, to lower blood pressures, to make the heart work more comfortably or easily. We certainly do things like thin the blood and address cholesterol, and medications provide us with a way of providing objective security. That the medications that we use typically have been shown to minimize risk, and that's why we use them. I think most people expect me to speak about ICDs. I mean, ICDs have been a big focus of our work over the past 2.5 decades about how do ICDs save lives, who do they save for, how do they work. And ICDs have consistently shown in the right kinds of patients with the specific kinds of risks that ICDs do, in fact, help prevent premature death. And there's no question that the people who take care of you, that the medical teams that you rely on, that they're also part of an objective security. That the process of medical care is not just a hassle, it's not just the annoyance of appointments, but the value gained is risk reduced. So the purpose of medical care, again, is to reduce risk and therefore activate a safety net. The purpose of medical care is to create security from the care plan and the team. So that is, the technology is pretty amazing, but it doesn't mean much if you don't feel cared about, or if you don't have a group of people that can hear your concerns, manage those kinds of thoughts and feelings with you, and produce security as a result. Think of it as sort of showing up with a set of concerns, have the team address them via both technology and expertise, and hand back to you a sense of security. Subjective security is the second kind of security that I want to highlight. And subjective security is one where I think that's a challenge that's a daily task. If you look at research into how people cope with medical problems of all sorts, regardless of what the threat is, there's a broad principle associated with it. And that is, most of us underrate our ability to cope and overrate the impact of problems. If you look at studies consistently about how would you ever cope with this or that or the other thing, people always say, I don't know if I could. And yet they do. I mean, if I said to you, hey, there's going to be, if I had stopped you in 2019 and said, hey, in a year or two, there's going to be a global pandemic, and there's going to be hundreds of thousands of lives lost, and it's going to lock down our world, we would have freaked out. And you say, I don't know how we're going to get through it. And yet here we are. The point is that coping is something that you really actually do know how to do, but you have to be more deliberate in how you do it under more intense stress. That is, taking good care of yourself, reminding yourself of who you are, where you came from, the strengths that you have, the things you've already gotten through in your life. Those are parts of a coping repertoire or a coping portfolio of things that you do that you may not recognize in yourself, but in fact you do. We've all coped with a lot this past couple of years, with the pandemic. I mean, that's an example of we can cope. It's just we would prefer maybe a little more comfortable way of going about life. But in fact, coping is something that most people can do, and that the difference is when under stress, you've got to be more deliberate in it. It's got to be more mindful of your coping strategies, more intent to make sure that you do reduce the stresses that you're reacting to. One of the ways I like to call this is that safety nets, in a way, are part of a set of subjective securities. That is, part of your thinking is, can you feel safe? Reminding yourself that you actually are safe. You are getting good medical care. You are connected. You are learning. You are connected to people who care about you. And feeling safe then is this idea of reminding yourself that despite the fact there is threat, there's also a signal of safety and a signal of hope. Hope is a critical element in our mental health. All of us need things to look forward to in order to feel good in the present. I always like the studies that sometimes show that most people like looking forward to vacation more than actually going on it. Meaning that everybody kind of has a crazy vacation where everything falls apart. Your plane leaves you, your bags are in Boise, Idaho, and you're in California or whatever, right? So, but the idea here is that confident thinking means reminding yourself that you're safe via the daily actions you take. Secondly, confident behavior or safety net behavior means that you're going to take steps toward living life and being active in your life. And then finally, relationships, right? Being engaged. So safe, active, and engaged are really the key elements here in subjective security. I like the idea of saying, can we take a selfie, right? Selfies and selfie sticks and all that stuff. People took selfies. And I think it's kind of funny, right? All these crazy selfies people put online. And I think it's kind of funny because I think it raises people's awareness of how they look. But I'm much more interested in a selfie that has to do with your emotions and your coping. That is, if you could take a selfie of your own coping process, if you could take a selfie of your stress levels, if you could take a selfie of how safe and secure you feel about your future, what would that look like? And I think that's the very idea that, like our culture, it's easy to take an outward picture and look a certain way, but how do you feel inside? And I like the idea of the old Rosie the Riveter, right? She was important because she represented that not only would Americans cope, but they would adapt and they would thrive under the stress of World War II. And in particular, in this case, the power of women transforming themselves in the crisis of the war to be effective and, I guess, create more machinery for the war efforts. But I like her because she's kind of come back around. But there's, for so many reasons, the longer you look at this picture, you see the determination, you see the confidence, you see the changes or adaptations in her that suggest that she knew she was under stress, she knew she needed to change, and not only did she do it, but she thrived. She can do it. Yeah, unfortunately, I think some people feel like this, right? This is this guy's Facebook picture. Oh, he's at the beach. He's doing great, except he's actually here, right? And that's a picture. And the very idea that we can put up fake book, I call it, fake. We can put up a fake front that suggests that we're doing better than we are. But the authenticism of our own emotional experiences usually will come back around. It's unlikely that not paying attention to your security will somehow create the kind of life you want, but rather paying attention to safety nets, you can actually be authentic and recognize you don't want to be that guy down there where he's just posing and not actually authentic. Our lifelines are part of how we do that. I always love the show Who Wants to Be a Millionaire, where people call on lifelines. And I think the same thing's true, that having lifelines from our families, but also our healthcare teams, that this is how safety nets are created in a subjective sense, subjective security, right? So taking a selfie with your family, taking a selfie where everybody's part of the picture, that's really what I'm getting at with subjective security. That subjective security means taking a picture of your own thoughts and your own Rosie the Riveter inside, if you will, or your family that drives the strength that you can draw from. A different way to say that is, what kinds of things are on your phone? Do they show quality of life? Are you engaged in quality of life pursuits? Do they show you enjoying the people in your life? Do they show you coping? I think it's important sometimes to take a look at that camera roll in our phones and say, how close are we to achieving the kinds of quality of life that we want? How are we overcoming some of the worries that are part and parcel to life, and particularly when dealing with a heart problem? And then how do we take actions toward those? That as we do that, we're sort of bringing subjective security to life. Because as I said, feeling safe is always a work in progress. It's very rare for us to ever say, well, I'm never going to be anxious again. Now I have everything I need. I'm never going to be anxious again. That feeling safe and recognizing safety nets is an ongoing work in progress. I'll finish with the last part of security that I want to talk about tonight, is active security. This has been an area of a lot of our work. More recently, I've been advancing the idea to cardiologists that one of the challenges of living with heart disease is that it's very much a disengagement disease, meaning that the natural response to somebody with any kind of heart problem is to withdraw from physical activity and to withdraw from mental activity, to actually avoid emotions or avoid activity. So that part of how I want cardiologists to think about this is that they must engage their patients, to actually draw out the idea that what are you doing in response to this? There's a tendency to hunker down, a tendency to withdraw, but I want you to re-engage. Not to be reckless, but to be engageable. And as I talk to patients and families tonight, of course, it's like, well, there's the other side of the table here too, which is to expect and discuss how to re-engage. Because it turns out when we actually ask patients to engage, it's hard for them to do. Here's a study where I'll call it free range cardiac patients. What they did in this study was they gave patients who were immediately after an acute coronary syndrome, so they had some sort of heart event, and they gave them all Fitbits. They gave them all wristwatches that could measure activity. And they said, here's the rules. We want you to get 30 minutes of activity 5 days a week. All right. Thanks for coming to the hospital. See you in 6 weeks. And then they looked at the data. And the data showed that only 16% of those patients were able to get close to that 30 minutes a day of activity for 5 days a week, meaning that 84% of heart patients left to their own just don't get much activity. They, in short, get disengaged. And when they asked, why did you get disengaged? Most said, I'm afraid to exercise. And 35% said, I'm sad, I'm depressed, and I don't see any way to re-engage. So that process, it means that they didn't trust the safety net that was put in place after their heart attack. That safety net of care and medications, maybe devices, it didn't do enough to make them secure to re-engage. Now, some people listening say, well, nobody's engaged, right? Come on, Americans don't do much. In fact, here you go. 30% of the data from Healthy People 2010 showed that 30% of Americans have no physical activity on a weekly basis. So 30% do next to nothing. So maybe heart patients are just part of that. Well, unfortunately, that's not really the case, because we also looked at patients with ICDs. And in this study, we looked at almost 3,000 patients with ICDs, and we looked at their they're devices that has a measurement of movement inside them, an accelerometer, much like a Fitbit. The only difference is it doesn't give steps, it gives minutes of movement. And what we showed was that in this large group of patients from 21 countries around the world, the average ICD patient only moved 3 hours and 5 minutes a day. So that means that almost 21 hours a day, the device didn't register any movement whatsoever. What that means then is that perhaps our patients with ICDs are, in fact, disengaging at higher rates than we perhaps understood. And if they get an ICD shock, they disengage at even higher rates. They can drop all the way down to less than 2 hours of movement a day. And it takes almost 3 months before the ICD patient, after a shock, returns back to that 3 hours of activity a day. And I just mean movement. I don't even mean physical. I don't mean exercise. I mean just getting up and walking about. Finally, that disengagement process particularly is hard on the mind. We showed that it took almost 2 years. If no treatment is provided after an ICD event, that it took almost 2 years for patients to feel like their anxiety was back to normal. So these two elements of feeling safe, whether it's your actions on the one hand, or it's your recovery emotionally on the other end, both of which lead our ICD patients to be disengaged more than we want. In short, the safety nets aren't really trusted. So what do we do? How do we become more, how do we get active security? Well, I think part of it is start small, right? So elicit help from, it should be elicit help from loved ones. Make small changes that can be sustained, right? So nobody is expecting you to go out and, run long distances. Instead, we're expecting you to be able to get up and begin a process that's stepwise and measured, and that your doctor can say, yeah, that makes sense to do. Monitor that, but also expect things to get in the way. And that remember that every little step matters. Importantly, that relationship of your loved ones and engagement can be a really important part of that active security. Because at the end of the day, if you feel safe, if you say, yeah, I got great safety nets, but you don't get much done, that is, you don't get to perform, you don't do the things that are the activities that you would like to do within reason, then the safety net's not quite in place all the way. In short, safety nets really do need to be involved. That is, the real safety net of creating medications and devices and care teams and families as an objective security net is essential. But that doesn't matter if you don't have subjective security. And that subjective security means that you remind yourself of the things you've put in place to keep you safe. And then finally, active security is the idea that because of the objective and the subjective security, it's safe to re-engage in life. And these elements are what's so important when we think about safety nets. Because it's easy to just say, oh, I got a safety net. Yeah, but tell me more about it. Remind yourself, be deliberate about how the safety net comes to play. Because at the end of the day, we don't want you living like this guy, the guy we started out with. That living in a safety bubble may in fact be something that would be easy or maybe even desirable, but it's hard to live life like that. It's hard to truly feel safe living it amongst bubbles like that. Thanks very much, and I'll be happy to take some questions at this point.
Okay. Thank you very much, Sam. And we do have a question that's been posted already.
Great.
And let me get to my chat box here. Okay, this is from Heather. Her son is a young adult with an ICD and has ARVC. And he tends to have shock anxiety when he's in a place where a shock would be bad, like on a chairlift.
Mhm.
And as his heart anxiety increases to the point that he thinks he's going to go into ventricular tachycardia, how do you recommend snapping him out of this and lowering his anxiety?
Great question. ARVC is, of course, one of the few conditions in which we do sort of pull them back a little bit from their activity level. So that's the one group, one or two groups that we worry about going too far, too much. But I love everything I heard in this question. I love that he's doing some stuff. I love that he's up in a chairlift. I think the first thing is to remind him that it's extremely unlikely that any of his reactions or feelings would cause a shock. That is, we use beta blockers, which are effective at blocking the sort of neurochemical signal of emotions to the heart. That is how beta blockers work. So the very idea that beta blockers are in play, and they are in the vast majority of the folks on the call, I'm sure, that I would really strongly encourage both you and your son to say, look, emotions aren't a trigger. When emotions trigger a symptom, it's almost certainly not a dangerous rhythm. In fact, it's probably something like a PVC that would not be dangerous in and of itself. Now, I like the idea of being on the chairlift with somebody else. So always a buddy up there on the chairlift. I'm scared to death up there on the chairlift. I mean, I'm a Florida guy. And those chairlifts look like they're for somebody that grew up with them, because I'm sure not comfortable with them. But the point is that both medications and a buddy and that device are going to keep your son safe. So I would be deliberate in reminding yourself and your son that the medications, the device, and buddies keep him safe, and essentially to ruminate on the security rather than ruminate on the anxiety.
Okay, thank you. So Kimberly asks, are you seeing any compounded impacts of COVID? For example, does combined stress require any different response?
Yeah, the problem with COVID is that we've all been under a chronic stressor. There are a number of things problematic about COVID. Of course, as a heart patient, you certainly have heard the message that heart patients are an at-risk group. So you have an unknown stressor. We didn't totally understand what COVID was at the beginning. We have an unknown duration, so we don't know how long this thing's going. We had unknown treatments, unknown prevention, and high stakes. I mean, that's an awful way to write the story of COVID-19 from a heart patient's perspective. So I haven't seen any brand new problems associated with it, but I've certainly seen that as one more thing. So many of my patients have said, in addition to everything else I got going on, I got this crazy pandemic going on. And so I've seen it more as an additive stressor rather than some sort of, it's all by itself causing huge problems. It's more that it allows anxiety and disengagement to be reinforced, because we have all had to disengage. So perhaps if there is a way that COVID, I think probably the nature of the question was, there is a way that COVID has had that effect, it's because it's allowed people to sort of withdraw, and there's good reason for it. And of course, I think it's really important, particularly after an ICD shock, once you've been medically stabilized, you got to get back out there. Otherwise, you will become disengaged, because there's lots of reasons to naturally go, well, I'm going to pull back. Good questions. Great questions, actually.
Okay, thanks. Here's another one from Yushika. I recently had an ICD implanted 2 months ago.
Okay.
The other night, she dreamed that she went into VT and saw an image of an EKG monitor that showed her heart rate of 288 beats per minute. In the dream, she remembered feeling like she was about to be shocked. Then woke up with my heart racing, she says. I had no idea I had this level of anxiety about being shocked. So I haven't been shocked in real life. Is it normal to have nightmares like this?
Yeah, so it's totally normal. Actually, there's some people on this call that have had what's been called a phantom shock. So phantom shocks occur in around 9 to 11% of patients. And basically that's exactly what it is, what happened to you, which is basically waking up, breaking of the hypnagogic reflex. So when we sleep, we have kind of a degree of paralysis. And then so suddenly we wake up, all of us have had that happen. You wake up suddenly, and if you don't have a defibrillator, you don't go, I maybe got shocked. But if you do have a defibrillator, you say, what was that? Now, phantom shocks are associated with people who have experienced multiple shocks. They're also associated with people with anxiety, depression, and drug use. And we've shown that actually in a series of patients that had phantom shocks that drug use was actually associated with it because it's kind of a hyperarousal state. And so the point is that I think part of the reason you woke up was that you haven't had a shock. And so if you'd had a shock, those memories kind of merge a little bit. Now, so what's that all about? I don't know that it means that you're having shock anxiety. It means that your mind's kind of working through that. We don't know a lot about dreams. I mean, it's sort of part of the myth of psychology and some early works by Freud and others about dreams. These days, we don't interpret dreams, or at least I don't. And I think it just means that you were kind of working through that. And in terms of waking up and feeling like you're tachycardic, again, the goal there is, look, you may have woken up with tachycardia, but allowing yourself to say, yeah, well, that was a scary dream, but I'm okay. Take inventory. I like to say that, take inventory, make sure everything's all there. Okay. If you're thinking, you're safe. Okay. I mean, when we're in danger from a cardiac rhythm, I mean, real danger, your consciousness will eventually be compromised. So if you're thinking, remind yourself you're okay. I'm thinking. I got it. I can feel myself, right? Is that Weekend who says I can't feel my face? As long as you can feel your face, you're on the right track. Was that Weekend? Somebody help me out there. The Weekend? I think that was the Weekend song. All right, what else we got?
Okay. So we've had several. Thank you for a great presentation, including Genevieve. And Genevieve has a question as well. If we are having a hard time getting back into activity after a shock, how can we bring this up to our cardiologist?
Great question. Boy, that's A+ for the lecture tonight on that, because that's exactly one of them. If I could do one thing with my work over the last 26 years, it would be to help cardiologists and patients immediately after shock get back into it. Once you've been medically stabilized, it's essential that you begin the stepwise process. So every one of my patients who comes to see me after shock, if they got shocked while swimming, we are not going to start with throwing them in the pool, but I want them to throw themselves in the pool after they get more confident again, meaning that restoring your life, not allowing that sort of subtle disengagement to occur. Now, I know that's easy to say and hard to do, but the settling out of the shock process means resuming, getting back to the activity. So if in this question, you said, well, how do I tell my cardiologist? I think you can say, look, I've been afraid to exert myself. Am I safe to go back to doing whatever it was that you were doing when you got shocked, or whatever it is that you want to do? Am I safe to do that? And the vast majority of activities are safe, but maybe you need to get some approval. And I think that's often the case. I'm always surprised because our cardiologists will say, you can go back and do whatever you want. But then the patient says, well, am I allowed to do X? Well, they just said do whatever you want. Yeah, I know they said that, but I mean, is it okay for me to play on the softball team? Well, absolutely, right? But there may be a break it down into bite sizes as opposed to trying to do the whole candy bar, right, of behavior. Bite-sized behavioral change allows us to sort of get your feet wet in returning to the activity rather than saying everything's exactly the same. No, everything's not exactly the same, but that process of getting back into it via small steps can be important. An example is sometimes what we'll do in clinic is we'll actually put patients on the treadmill and let them go ahead and exercise and show that, see, you're exercising at this fast right now, it's clearly okay to be gardening again. If you can do that in the clinic, you can garden. If you can do this in the clinic, you can play on the softball team. That's no problem. And so I think finding ways in which you remain committed to engagement again, that wins the day.
Okay, thank you. Here's a question. Do you have any suggestions for dealing with the side effects of meds? Tired, sluggish, no zest for life?
Okay, so great question. So fatigue and sort of spark or energy, those things are directly affected by some of the medicines we use. Now, we argue about this in the scientific literature about how much beta blockers and calcium channel blockers and ARBs and the different meds we use with you affect fatigue and sort of mood. We argue about it all the time, but I mean, all day, every day, we see that. Now, remember, part of what we're doing with those medicines is we're going until you can't tolerate them. Okay, let me say that differently. Most of those medicines, we're using them, we're going to titrate them up until you tell us that's too much. The reason is because we want to get control of that heart rate and blood pressure. So it is often the case, and this is my tip, if you're feeling tired and worn out, it's important that we hear that, and we probably will back you down a little bit and see if you tolerate it at a lower dose. But the general principle is to start low and go slow, but keep going until there's intolerance. We want control of that heart rate. I know that seems silly, but that's the nature of blood pressure control. It's a very weird blood pressure heart rate control. So it's a weird game we're playing. It's basically like keep pinching until they holler, right? Keep going for that blood pressure and heart rate control until they go, stop. I feel like I'm going to fall down. Okay, that's too much.
Okay, from Katie. Dr. Sears, I was struck by your discussion of the way medical practitioners can not only add to the objective safety of a patient, but their subjective experience of safety. Has any of your research looked at what happens for patients whose disengagement is partially or wholly caused by medical practitioners whose style of care does not add to their subjective safety?
Wow, that's a big question. So let me explain a couple of things that tell me that are analogous to this. So when I first started working with ICD patients, and I'm talking about 1993, we had devices that were kind of dumb and they just shocked kind of dumbly. Okay. And I remember a case I saw of a young lady in which the paramedics got to the scene and freaked out because the patient was getting repeated shocks. And so in every way, the paramedics basically communicated fear. Now, another story. It's very often the case that different kinds of doctors know about different kinds of things. So you may go to a family doctor and they don't want anything to do with you because they don't want to know about that device and they don't want to know about that genetic condition because that's not something they feel expert on. And so they send a fear message by saying, yeah, talk to the hand. In both of those cases, whether it's a paramedic, whether it's a different kind of doctor, they can send a fear message to the patient. And so it is the case that it isn't just necessarily your doctor, but it can be anybody in the medical establishment that ends up sending a fear message when in fact, it's a very clear idea. We do know how to keep you safe with devices and medicines. That is, we are trying to build a care plan in which you can be active. So if you're dealing with a provider that really is fearful for whatever reason, or sends a message or doesn't provide you with the confidence to re-engage, I think it's worth directly asking, like, am I safe to do what I want to do? And whatever that is. Am I safe to go see the Buccaneers play football? Can I go up in the stadium? Am I safe to go to the roller skating rink? Am I safe to do whatever it is you're trying to do? So that maybe you are, you're confronting the idea that maybe they don't know they're sending a fearful message. And the reality is that we don't want, I mean, it's almost cruel to put a device in somebody and then say, okay, don't live life. What? That takes the value out of it. So we want you getting back. And I think as long as you start to communicate that the best you can, that both you and your family's expectation is we want to do all we can. I want to be right on the limits. I want to maybe not push the limits, but I want to know where the limits are. I don't want to just be so disengaged. I don't know where I can live and not live.
Okay, thank you. So Danielle asks or comments that she's a long QT type 2 patient, and she has a 12-year-old daughter who witnessed her losing consciousness and received multiple ICD shocks. And she said, we have been unsuccessful in reducing her anxiety and trusting my safety nets. Could you speak to this at all? And maybe general mental health effects on loved ones or those with ICDs or who have witnessed cardiac events like this?
Yeah, so this is a tough one. I didn't catch the age of the child. Was it 12?
12. Yes.
Okay. So the reason I asked the age of the age of the child is the developmental considerations, right? So if you told me the child was 5, that's a very different answer than if the child's 12, right? It has to do with the ability to abstract reason and to consider and forecast the outcomes of things. As you get older, you can see the next thing before it happens, kind of thing. All right, so for a 12-year-old, first and foremost is to reassure the patient, reassure the child that you are safe, and that here's the ways I'm keeping myself safe. I have a device. I have a great doctor. I take medicines every day. I'm active and I'm engaged in my life and my care. And those are the signs that tell you that I'm safe and gonna be here for the long run. So give the evidence, actually give enumerate the daily efforts to create safety and ensure future. Again, I talked about the importance of hopefulness, and we've got to reintroduce hope to this 12-year-old, because all that 12-year-old knows right now is fear and loss, or the potential for fear and loss, and that drives anxiety. So I think re-engaging that you are doing things to stay safe, that there is going to be a future here, and that you have a plan to keep the child safe forever as well. So that even if no matter what happens to you, you have a plan to keep her safe too. So help reassure both that you're okay and that she's okay. I know that sounds trite, but that idea that we are actively dealing with this, what's happened, and that we've got a good plan in place and we don't expect this to happen again. Now, having said all that, that's the sort of a generic plan. For this particular 12-year-old, it may be the case that she really does need to have an opportunity to talk about what she saw and what she felt, that there can be some true traumatic stress that's occurred for her, that all that reassurance I talked about just ain't enough, that what she might need to do is just simply talk about it and just know that, yeah, it was scary. It is scary when somebody you love's in trouble. It's helpless feeling. But on the other hand, the strength of a family, the strength of each other is that even when that horrible thing happens, we got through it and we'll get through anything else that comes. So there may be an opportunity which she just needs to talk it through. It doesn't have to be deep psychotherapy. It just simply say, I was scared and I don't want to scare my mom by telling her that I'm scared again. And they just need somebody else to talk to do that. A child psychologist can usually do that. We're not talking about years of therapy. We're talking about a short-term debriefing. What happened? What did you see? What did you feel? And then how do we prevent that from creating a daily kind of reminder or hyper arousal that somehow leaves them on edge? Rather, we simply say, look, we got this. This family together, we got this. That's what that 12-year-old needs to hear.
That's wonderful. Thank you, Sam. So Bob just commented, so he let everyone know that you volunteered to experience a defibrillator shock. So you knew how to better relate to patients. And Bob says, I know it makes me question his sanity, but it also makes me respect his input more.
Yeah. Well, thank you. I did have that occasion. I was at one of the device makers and they had a machine to actually do it. I shocked my arm. While I didn't get the full energy, so I can't take full credit, but I did get a good solid shock. And even to this day, which has helped me, he's right, it has helped me a great deal because I can kind of call up in my memory what it felt like, even though I wasn't in harm's way. But the point is, it's such an unusual stimulus. You know, electricity is a very strange stimulus to animals with spinal cords because it creates a contraction and relaxation at the same time. That's why you get stuck, right? Because both sides are contracting of muscles that should give and take. You know, the bicep, tricep should give and take, but when you're electrified, both are tight. And so it really is the case that it did help me understand the kind of muscle memory or stimulus memory of what electricity feels like.
Mhm.
So I don't know. I appreciate the shout out. I'll try to do something a little more heroic than just sign up for that. Okay. I'll try to actually do something that changes the planet instead of, you know, I'm a dummy that did that. Try to come up with something better.
Okay, Kristen asks how she can find a cardiac psychologist in her area. She has a regular therapist, but wants to, you know, doesn't feel like that this person understands her total situation. So is there a way to locate someone like you? Maybe not as
Okay,
good as
that's
you.
a big
but,
trouble. This is a very important matter to me in terms of creating more people that can speak fluent cardiology and fluent psychology. The reason is because that's what we're asking you to do. And so this is really an important issue. Unfortunately, my answer is going to be there are very limited people who know how to do this. The only easy rules of thumb are to call the state psychological association in your state and ask for a health psychologist. So a clinical health psychologist typically is a psychologist who has training in the psychology of disease. So here at East Carolina, we're one of the 7 schools that's focused on training psychologists to deal with the stresses of disease, not mental health per se, but the stresses of disease. So we have somebody who's focused on cancer, somebody focused on heart disease, somebody focused on family medicine, women's health, and neurologic problems, and pediatrics. We're still not everywhere we want to be, but the idea is some of my trainees are across the country. So that's really the only easy way. You can always ask your cardiologist who they refer to. And I think you can always, bring some articles with you to your therapist and say, hey, this is an article I found from this bald-headed guy I watched on a Monday night, and he wrote this, and this might help you. And bring something. Let them bring something to read. Participate. Engage. That is, you're going to have to be more than a passive patient to really get everything that you want. In a way, it's understandable. How could every psychologist know something about everything? They can't. But there are some principles in place. All people coping with disease are trying to find control. All patients coping with disease are dealing with family members who are along for the ride. And so there are some commonalities, but there are certainly, there are not a lot of psychologists who are going to say, hey, tell me about your long QT2. And that just ain't going to do that very often.
Okay, well, thank you for your presentation, Sam, and we welcome all the questions that we've had and the interactions in the chat field. It's been wonderful. So we appreciate you volunteering your service tonight, and thank you all for joining us.
Thank you so much. I enjoyed it. Good night.
Good night.